Hi everyone, I'm Ben. I'm one of the PEDS trainees on rotation in neonates at the moment. And after implementing the Procalcitonin guideline a couple of years back to try and proactively stop antibiotics and help get kiddies home quicker, I thought it'd be quite useful alongside some of the consultant team to do a bit of a refresher and put Procalcitonin back in everybody's minds so that we're thinking about it. And so what we're going to do today is think about antimicrobial stewardship and how procalcitonin is a key player in that and what our role is and why we're hoping to use it. So what we're hoping to do is explain what we mean by antimicrobial stewardship, understand procalcitonin and its role in acute infection, particularly in neonates, and then apply antimicrobial stewardship principles with the help of procalcitonin. And we've got some examples coming up at the end just to really put it in a clinical context. So the phrase antimicrobial stewardship, well, where this is all coming from is that actually, yes, antibiotics are good, but they're not without risk. So there's loads of antimicrobial resistance. And actually, giving lots and lots of antibiotics or giving antibiotics in themselves does actually increase the risk of getting gram-negative bloodstream infections. So really high impact in terms of our fragile neonates. So it's everybody's responsibility to think, is this the right thing for the baby? Is this course duration, 5 days antibiotics, actually in the baby's best interests? And it's a shared decision making, but it's everyone's responsibility to say, actually, is this right? Or could we do something even better? Other aspects of antimicrobial stewardship, we've got appropriate dosing, thinking around, certainly in older children, do we need it to be IV versus oral? Thinking around checking levels. So that's the reasons we do gentamicin levels, is to make sure it's not toxic. We're not overdosing on these antibiotics if the kidneys haven't quite processed it. And thinking around allergies as well. So all things, and this is a nice pretty diagram, just really highlighting that it's not just something in isolation. We're not doing procalcitonin because it's a fad or because it's the new kid on the block. It's because it's really important that we're trying to prevent ongoing infections. We're trying to effectively manage these babies. We're thinking around upskilling ourselves, getting our knowledge out there, and really making sure that we get babies home as quickly as safe to do so. To put this into context, early onset sepsis accounts for, so around 1 in 10 babies are getting antibiotics within the first 72 hours of life, which is really quite a high amount. But only 1% of those 1 in 10 actually ever have a blood culture positive result. And there's a fair few of them which are contaminants, so a kind of a false positive. So we're thinking it's a really, really, really small number of blood culture positive infections. And so it's never ever wrong to start antibiotics, but we need to think really long and hard about actually, is it appropriate to continue them based on the information we've got in our disposal? Because there's a burden to the baby, cannulation, staying in hospital, sometimes being separated from mum. There's the burden to the family, that anxiety of staying in hospital, the unknown as to whether it's an infection, seeing the cannulation attempts. And then also we need to think about patient flow. So bed blocking units, the cost of an admission for the baby and mum. And so most of what we do is based around CRP, which is a non-specific sign of stress. There are lots of reasons why CRP can be raised. It can be raised in infections, but it can be raised in lots of non-infection processes. Procalcitonin, or PCT, is significantly more sensitive than CRP, and it's really good at saying, is this a bacterial infection, yes or no? And if it's low, it's no. PCT is always raised with a bacterial infection. So a low PCT is reassuring, regardless of what the CRP is. And it should trigger us to think, can we stop these antibiotics safely? So procalcitonin itself, well, it's an endocrine hormone. It's a protein produced by cells in the thyroid gland, and it's significantly raised in bacterial infections. various cellular pathways, immunological pathways, stimulate its production. And there's a really, really rapid change. So while CRP, we always say that's actually reflecting yesterday or about 24-hour delay, PCT is really specific. So within 2 to 4 hours of a bacterial infection taking hold of the baby, it will demonstrate a rise in PCT. And even more reassuringly, in response to antibiotics, it drops really quickly if you've got effective antibiotics on board. So it's really sensitive and it's really specific for a bacterial infection. In different settings, it's useful to monitor response. Like I say, it drops really quickly in response to appropriate antibiotic coverage. So it's not common in neonates that we end up changing antibiotics because we don't think they're on the right ones, but it could be something else for people to think about in a different guise. And where it's coming from here and why it's in our minds is that it's really useful to safely reduce antibiotic use. Again, the emphasis is not, shall we do it to begin with and maybe not start antibiotics? We're starting antibiotics in neonates for either risk factors or clinical worry, and you always want to get that in within the golden hour. But once we get reassuring infection markers and a reassuring examination, can we proactively stop the antibiotics? There's some pretty pictures as to the process as to how procalcitonin is produced in response to a bacterial stress, but they're not really something I want to go into great detail about. Mentioned a number of times about it could also be raised in other situations. So whilst it will always be raised in a bacterial infection, it could also be raised in different things. And for our neonatal population, hopefully not on the postnatal unit having cardiogenic shock, but maybe on the neonatal unit if we've got very, very poorly babies. But thinking around congenital anomalies, even if there's an extra digit, that could be enough to have an erroneous PCT level. So we do need to be mindful of when it is appropriate to use. And on the neonatal unit in particular, severe respiratory failure or being preterm to massive potential causes for raised PCT. And there's this physiological elevation in a newborn baby. Every baby's is probably slightly different. And that's why we don't do it with the first CRP, because international guidelines and international evidence base would suggest that after 24 to 36 hours, we do see that decline. And that's where we've got our reference ranges from that we've put on the guideline. So how can we use it? Low levels of procalcitonin will help decision-making, proactively stopping antibiotics in early and late onset sepsis. So it's really going to help reduce the time babies spend on antibiotics, and that's really good antimicrobial stewardship. Like I said, on the neonatal unit, it might be that an initially raised CRP, PCT that's then coming down will show that we're on the right antibiotics, so that's good. And if it doesn't come down, it might trigger us to rediscuss with microbiology. An increase in PCT in the absence of a positive blood culture is still highly indicative of a bacterial infection. So we only ever take around 1 ml of blood for a blood culture. And if you think about how much blood is in the body circulating at any one time, that's a very small fraction. And if we've managed to take that blood, screen the baby very early on when they've shown very subtle signs and they get more poorly, it's very reasonable that we won't get a positive blood culture, but there's clearly an infection. So if we have a high PCT in that situation, that could be strongly suggestive of a significant infection. And where there's a positive blood culture but low PCT, it's useful to discuss with microbiology. So could this be a contaminant? Could there be something else going on? It's a weird situation that probably won't happen, that we do need to bear in mind and escalate if need be. I think it's useful to have the reference ranges. So in you and I, it will likely be undetectable. We won't have any circulating procalcitonin. And if you're slightly stressed or just one of those things, it might be less than 0.05 if we're able to detect it at all. We would say less than 0.5 would be reassuring. So there might be some stress. It's worth thinking, if we're strongly suspecting infection, do we repeat it at this level maybe? And if it's greater than 0.5, then we think there probably is a good going stress. Again, is that infection or have they had surgery, for example? There's significant stress. So again, slightly ambiguous. But greater than 2, it's an infection until disproven. And greater than 10, you'd have a strong suspicion for sepsis. And then this is the guideline that we've produced. And like I say, this is a combination of consultant neonatologists, the consultant microbiologists and microbiology trainees, and utilizing data from national and international studies. So it's not without consideration. Important things to point out is it's not being done with the first CRP. It's not being done with the initial septic screen. And we're not waiting for the result before starting antibiotics. We're starting antibiotics based on either risk factors or clinical suspicion. And we're not doing them for early onset sepsis in less than 34 weeks gestation. So that may have an impact on some transitional care babies, or if we've got significant congenital malformations. So if we're suspecting trisomy 21, if there's extra digits, gastroschisis, or other surgical problems. And then, as you can see from the flow chart, we've got green, amber, and red, all giving us different potential management steps. And you can see again how this natural elevation, physiological rise after being born is mimicked in the levels. So initially, we're saying a green or reassuring procalcitonin at 24 hours of life is anything less than 5. But if that level was taken on day 3, 4, that would be in the amber or the red category, because we'd expect that physiological rise to decline over the first 2 or 3 days of life. So green, almost certainly going to stop antibiotics unless there is clinical concern. Amber, we suggest repeating in 12 hours. And then red, you're likely to be continuing antibiotics. And if it really, really, really doesn't fit, i.e. it's one of those few children where the physiological rise is significantly higher and it's unexpected, then discuss with a colleague. There's a couple of videos on procalcitonin and the nice guidance, which I thought were quite useful. I'll leave them there in case anyone zaps them mid-presentation. So, when are we going to use them? Well, in neonates, it's when we're trying to discontinue antibiotics and when we're maybe trying to figure out, is this a bacterial or a viral infection? When we're not going to do it is if we've already confirmed an infection. So if the blood culture is positive or they've got radiological NEC, there's not really a great deal to gain from doing a procalcitonin other than spending money, because you're not going to stop antibiotics based on it. It might be useful further down the line if they're still poorly and they're not responding to treatment to get a baseline or a comparison. But certainly if they're doing 5 days of antibiotics, we don't need to prove that it's coming down. And then, like I mentioned, that physiological rise in the first 24 hours of life. So it's probably useful just to try and anchor the guideline mixed with our kind of background knowledge and a clinical presentation. So baby Smith is a term baby who's day 2 of life and is being treated for suspected sepsis due to multiple risk factors. They had prolonged rupture of membrane for a week and mum was on the sepsis bundle. They've had normal NEWT scores throughout. They were a normal delivery, feeding well, and they've opened their bowels and passed urine. They've had a normal NIPE examination and a normal assessment by the LST, and the parents are not concerned. Their first CRP was less than 5, but their repeat CRP was 28. They have a PCT at 24 hours of 0.8, and blood cultures are in the lab. There are some recent observations at the bottom. So what will you do? So currently we've got a rise in CRP, we've got a reassuring PCT and a normal examination. So the guideline would suggest that we stop antibiotics after discussion with the consultant. We have a CRP rise, but we've got a clinically well baby and a low procalcitonin. Guidelines say stop. Consultant agrees, and the baby goes home at 24 hours of life, so not even needing to wait for the 36-hour blood culture. The blood culture is then chased up by the junior trainee because it's been left on the bottom of the list, just in case. and that's negative. So that saved a number of hours in hospital for the baby and discontinued the antibiotics really early, stopping that extra dose. And that's the right thing to do. Baby Bibi is a 32 and 4-week baby who's day 2 of life being treated for suspected sepsis due to risk factors. They are a preterm delivery who had prolonged ruptures for the last 5 weeks. They've got normal observations on the neonatal unit at St. James. They were a normal delivery and they're tolerating their feeds well at 90 per kilo via a nasogastric tube. They've had a normal NIPE examination and the nursing staff are happy with their progress. Their initial CRP was less than 5 and their repeat CRP was 10. Their procalcitonin was 9.8 and their blood cultures are pending. Set of observations at the bottom. What will you do? So we've got a CRP rise, we've got a high procalcitonin, but a reassuring examination. And there's the guideline. So the guideline says they're too young to have done the procalcitonin. They're likely to have a higher physiological rise because they're a preterm baby. And so it's a non-reliable PCT result and we can disregard it. There's no need to repeat it because what does it mean? What's it going to change? In this instance, we're going to be guided by the CRP and the blood culture. So a small CRP rise to 10, negative blood cultures and a reassuring clinical examination. So in this instance, we'll stop the antibiotics. Baby Arnold is a term baby, day 2, being treated for sepsis. He had one risk factor and was found to be persistently tachypneic. So mum has been treated on the sepsis bundle. He was a Cat 2 section for failure to progress, having been induced, and had some meconium at delivery. His respiratory rate was high on consecutive NUTs, but didn't have increased work of breathing. He was reviewed by junior members of the workforce a few times, and they felt that it was persistent enough to start some antibiotics. By 18 hours, the respiratory rate was completely normal, it's feeding well, and has had a normal NIPE examination. The initial CRP was 9. The 24-hour CRP was 36, and the procalcitonin was 1.5. The blood cultures are still outstanding, and the recent observations are below. What will you do? So we've got a CRP rise to 36. We've got a reassuring procalcitonin and a normal clinical examination. So what could be going on? Well, there were sections, they weren't in labour, so it's possible they've got some transient tachypnea of the newborn and that's settled down. It could be sepsis and that was the right thing to do to start antibiotics. And if the tachypnea had persisted or gone into oxygen, we would have got a chest x-ray, we might be more concerned. But things have settled down, which is great, and we've had a reassuring procalcitonin that says we should stop antibiotics. And so it was discussed with the consultant on call because actually we've just started this guideline and the CRP seems pretty high and normally they get 5 days of antibiotics and they did have a high rest rate. And they said, but you've got serial examinations that are reassuring and we've got a normal NIPE and normal observations and there were a section. So there is another reason for the high rest rate. And so they're in agreement that we can stop antibiotics based on the procalcitonin, and so the baby was home by 24 hours of age. Blood cultures were chased up the next day and they were negative, and that's the right thing to do. Baby Mackenzie is a term baby treated for sepsis because of low sugars and inability to maintain their temperature. They were an elective section due to previous sections and needed no resuscitation at birth. They had a low sugar, which came up after a feed, and that's been fine since. They had a low temperature of 36.3 in recovery, warmed to 37, but while on the postnatal unit, it dropped again to 36.3, despite feeding well and having regular skin to skin. They had a normal NIPE examination, normal observations, an initial CRP of 28, That's risen at 24 hours to 36, and we have a procalcitonin of 5.2. Blood cultures are pending, and they're the recent observations. What will you do? So a CRP high to begin with has risen to 36, with a procalcitonin in the amber category, but a reassuringly normal clinical examination. So we've got a CRP rise and an amber procalcitonin. We've not really got a good reason for the low temperature and sugar. So we need to have in our minds, could this be sepsis, which is why we started antibiotics. But it's great that they're now doing really well. So the guideline says repeat procalcitonin in 12 hours because they're in the amber category. The procalcitonin at 36 hours was 1.9, which puts us in the green group. Baby is clinically well, and procalcitonin is now reassuring. So this was discussed with the consultant on call, and they agreed that the antibiotics should be stopped. Baby goes home at 40 hours of age. Blood cultures are negative. That would almost always have been 5 days of antibiotics. And so again, it's bed days saved. It's a good clinical course, and it's the safe and correct thing to do. Baby Agbo is a 37 plus 5-week baby treated for sepsis due to 2 baby temperatures. They were a normal delivery with no resuscitation and a normal antenatal period. They spiked a temperature of 38.6. They were reviewed and felt to be well, so gave them the benefit of the doubt and thought, could this be environmental? And then at 7 hours, they had a temperature of 38.5. They were reviewed, they looked well, but 2 genuine temperatures, so they were screened for sepsis. They had a normal NIPE examination, have had normal NEWT scores throughout apart from the temperatures, and they had an initial CRP less than 5. Their 24-hour CRP was 70, with a procalcitonin of 2.2. Blood cultures are pending, observations below. What will you do? So we've had a significant CRP rise, a reassuring procalcitonin, and a normal clinical examination. So the early onset guideline will tell us that a CRP greater than 50, in line with NICE recommendation, needs a lumbar puncture. We've still not got a reason for those genuine temperatures. So whilst the PCT is reassuring, it may not be a bacteremia. 1, we've not got enough evidence base at the moment to say that categorically is the right thing to do. And 2, we've got NICE regulatory guidelines that say CRP greater than 50. We need to err on the side of caution and make sure we're doing the right thing for this baby by investigating further with a lumbar puncture. At 36 hours, the procalcitonin remained low. The blood cultures were negative. A lumbar puncture was done, expertly done with no red cells. And a further 24 hours on from that, the CSF was negative. The baby was clinically well throughout with no further temperatures. The procalcitonin was reassuring, but we're not in the place to go off that alone when the CRP was so high. It was significantly high, triggering a lumbar puncture. And by the time the CSF cultures came back, we were day 4 anyway, and we would normally complete a 5-day course of IV antibiotics, which is what we did. The asterisk here is that negative growth and a reassuring PCT means that this CRP rise was almost certainly not because of a bacteremia. So watch this space for the future is the point here, I guess. Baby Agbo is back in a slightly different guise. So same backdrop, 37.5, day 2, treated for sepsis because of multiple temperatures. You've heard the story before, multiple temperatures, clinically well, but screened for sepsis. Normal examination, normal NEWT scores. CRP was less than 7 to begin with and has risen to 70. Now in this parallel universe, the procalcitonin is 21.2. Blood cultures are pending, so what will you do? We've got a significant CRP rise in a clinically well baby. We've got a significantly high procalcitonin. So the guideline would put that in the red category, firmly in the red category. So consider additional investigations, which is what we were going to do anyway. So high CRP in isolation would trigger that lumbar puncture. Given that that correlates with a high procalcitonin, we're definitely going to do that. And in this situation, the procalcitonin doesn't really come down very much at 36 hours. And our blood culture at 36 hours pings positive for group B strep. Thankfully, the lumbar puncture is still nice and normal with a champagne tap and no CSF growth. The baby remains clinically well throughout. And after discussion with microbiology, given that it's blood culture positive but CSF negative, they were happy with a 5-day course of IV antibiotics to treat group B strep. And again, the thinking here is high procalcitonin is a real high indicator of bacteremia. So we're almost always going to continue antibiotics. And in this case, the blood culture became positive. Last one, we've got baby Potts, who's a 42-week baby treated for suspected sepsis due to risk factors. We're in emergency section for shoulder dystocia and meconium liqua. Mum was treated on the sepsis bundle and there was suspected chorioamnionitis. They were tachypneic on assessment at 2 hours, but an otherwise normal examination. They have had a normal IP examination, normal observations after that initial tachypnea. The initial CRP was 6, the repeat CRP was 12, procalcitonin's 11, and the blood cultures are pending. So what do you do? So we've got a CRP rise, a red category procalcitonin, or a bit polycythemic on the full blood counts, and we've got a normal examination in the red category. So in this instance, we've got a clinically well baby with risk factors. The procalcitonin doesn't really fit with the clinical picture, and the guideline would say repeat PCT at 12 hours and consider either escalating or doing other investigations. On balance of risk, given they're very well, we felt doing a repeat procalcitonin at 36 hours was appropriate, and that's still in the red zone. Now, on the neonatal sepsis drop down on ICE, the procalcitonin comes combined with a CRP. So you've handily got a third CRP, even though we wouldn't traditionally do it as standard. And that's nice and normal. It was discussed with the consultant. The procalcitonin really doesn't fit with the clinical picture. And it could be one of those outliers where there's a slight delay in that physiological decline, because it can be raised in neonates anywhere up to 48 hours of life, and we're in that window. So after serial assessments being clinically well, reassuring inflammatory markers and blood cultures, consultant decision, happy to stop antibiotics. And that's an important anomaly to think of, because it does happen, particularly on the postnatal ward, and you then worry about committing to 5 days of antibiotics just based off of PCT. It can be high for other reasons, but it will always be high if there's a bacterial infection. So a low procalcitonin is always reassuring. A high procalcitonin should make you say, oof, does it fit? So just to hammer home the take-home messages, I guess, antimicrobial stewardship is really important, and it's absolutely everyone's responsibility. So we should all feel empowered to ask the question, is this the right antibiotic? Is this the right course duration? Is there anything else we can do? Is this baby safe with the antibiotics they're on? Procalcitonin should be at the front of our thinking, and we're wanting to use that to help reduce antibiotic use, ideally to get babies home quicker, but this is all about safety. We're not being cavalier here. It's all about safety and having additional layers to try and help these babies on their journey. A high CRP, but low procalcitonin should mean stopping antibiotics, sending babies home, and not delaying discharge to wait for the cultures. Thank you very much. And hopefully we get some babies home nice and fast. Thanks, guys.